But now today also my other awesome coworker, Kelly. Kelly is a doctor trained and board certified family nurse practitioner serving as the Associate Director of APP Provider Initiatives with PMD Alliance. After completing her Bachelor of Science in Nursing at the University of Wisconsin-Oshkosh, she completed a Master of Science in Nursing and a Doctorate in Nursing Practice from Frontier Nursing University in Hayden, Kentucky. She has extensive experience as an advanced practice provider in neurology and patient case management, with over 5 years of experience specializing in movement disorders. Her experience includes neurology assessment, diagnosis, treatment, and management of patients with a variety of movement disorders, including Parkinson's disease, essential tremor, and Huntington's disease. Kelly, we're so happy you're with us today.
Thank you. I'm so happy to be here. I'm excited to get to be in front of all of you and share this hour with you.
I should also preface, if anybody has questions, please just put them in the chat and we'll get to them at the end. Thank you.
Great. So today I want this to be interactive. As I go through these slides, if a question pops up, please put it in the chat as Eden mentioned, and we will circle back to it. I'll answer all the questions that I have time for. And I'm excited to talk to you today about the clinical and social considerations as we see disease progression in Parkinson's disease. So I'll just briefly remind you, if you've been on these before, you are likely familiar, but Parkinson's disease was first described in 1817 by James Parkinson, as it is the second most common neurodegenerative disease, second behind Alzheimer's, but the fastest growing. In fact, new data just came out in the last month that when we used to think there was 60,000 annual new cases in the United States of Parkinson's disease, there's actually more like 90,000 annually just in the United States alone. So this is a very much the fastest growing, and it's related to a dopamine deficiency. So what happens, there's a loss of dopaminergic neurons, which produce dopamine. This takes place in the substantia nigra of the basal ganglia, the movement center of the brain. And that reduction in dopamine, it results in the key motor function or feature deficits. So slowness, stiffness, tremor, imbalance, and stability. Those are the key motor features that we see in Parkinson's disease. This might look familiar to you. So as we're talking about the clinical implications, I'm going to first just talk about staging. A lot of people, when they are themselves diagnosed with Parkinson's disease or their loved one is diagnosed, they ask, what does that mean? What stage am I? It can be a difficult thing to stage, and there are many different scales out there, but the modified Hoehn-Yahr is one of the most commonly used, and you can see here it goes from 1 to 5. This scale is used to describe the symptom progression, and it was originally described in 1967. It was later modified in 1983 to add the 1.5 and the 2.5, and that's just to account for some intermediate course in disease progression that we see. This does not include non-motor symptoms, so if you look at this scale, it's really just talking about the motor features. 1 means that there's just one side involvement, very mild. All the way up to 5, which could indicate that someone is wheelchair bound or bedridden. There's another way that we look at this. Sometimes people might mention prodromal stage, which means before they're diagnosed, prodromal symptoms, early stage or middle stage, and then advanced stage and late stage. For the sake of this talk, I'm going to talk about advanced stage and late stage kind of as one. But over the past 2 decades, it's been studied and become more well known that there is actually a subset of patients with advanced Parkinson's disease who progress into a later stage, which is clinically different looking from advanced stage Parkinson's. And we call that late stage Parkinson's disease. But for the purpose of this presentation, we'll consider advanced and late as one. And those really can be, Hoehn-Yahrs of 4 and 5 when there's severe disability, cognitive impairment, motor and non-motor complications. This is a nice graph to just kind of understand what symptoms might be associated in different stages of the Hoehn-Yahr. And you can see across the bottom, the HY1, that's Hoehn-Yahr 1, all the way up to 5. The red graph, or the red line, is showing us a change or an increase or decrease of motor fluctuations and dyskinesia. Classically, Parkinson's disease progression is marked by the severity of motor symptoms, the patient's appearance, their physical dependence, and motor complications. And again, the Hoehn-Yahr does not take into account the non-motor symptoms, which we'll talk more about in just a minute. And that blue line, that's the Schwab in England activities of daily living scale. So as you can see earlier in the early stages of Hoehn-Yahr 1 or 2, you have high independence of activities of daily living, whereas we might see in disease progression that that scale goes down and there's less independence in that. So first we'll talk about the advancing motor symptoms, decline in mobility, falls, loss of dependence, perhaps a need of increased medication. So we'll go into these each individually. When we look at the decline in mobility, that can be in gait, which we frequently associate this with. Freezing of gait increases with advancing disease. We also know that falls can become more prevalent. I just want to put out there that all of these different symptoms that we talk about today, whether they're motor or non-motor, not every person will experience them, and not every person will experience the same severity of them. And so if we mention something, you may not ever experience that in your journey. You might not ever see your loved one experience that. But these are things that can occur. And we know that freezing of gait, because it can relate to falls and a setting of frequent falls, is puts you at a higher risk for higher mortality. Also loss of independence with activities of daily living. Loss of independence is a huge consideration when we're talking about the clinical implications of advancing disease. It does have a higher need for caregiver support, higher burden of caregiving needs, which can increase financial strain. Of course, loss of driving, if that's still an ability for some people, can be very detrimental. However, again, this is only applicable to some cases. But these are things that we see in the loss of independence that really needs to be taken into consideration when we're looking at this as a clinical picture. One of the things that we see with this is the motor fluctuations, the dyskinesia, that involuntary dancing movement, the off time, freezing of gait. When there's an increased need for medication, we have an increased risk for side effects. And we could treat dyskinesia. We can add a medication to that. We can treat off time. We can add to the baseline therapy. We can add an on-demand therapy. We can add an adjunctive therapy. But again, there's always that risk of increased side effects. So when we look at polypharmacy, this is a very real thing in Parkinson's disease. There is nothing convenient about Parkinson's disease, and the medication administration is no exception. It's just a tough thing. I just want to talk to you a little bit about when I'm in clinic and if I'm seeing a patient and a person with Parkinson's comes in, and we know this is a head to toe disease. This can affect cognition. This can affect freezing of gait with your feet. There are many things that we could address, but in the short amount of time that we get with somebody, I want to make sure I'm addressing what is bothering that person the most. And this is something that I would never go without asking. I asked every single person I saw, what bothers you the most? What can we talk about today? I'm going to show you a couple case studies. These are not necessarily late or advanced stage Parkinson's patients that I saw, but they just demonstrate something that I want to talk about. And you probably are all familiar with like electronic medical record, Epic, or an opportunity to be able to message your provider and say, hey, I just wanted to check in on this medication. These are messages that I received from people that I was seeing in clinic. So this first one is a 72-year-old male, has a 5-year history of Parkinson's. And he wrote to me complaining of increased agitation and irritability over the past few months. He was concerned that the medication he was taking, the new medication he was taking, was affecting his mood. He had fragmented sleep with REM behavior disorder and was sleeping more than ever during the day. Some of these terms, if you're not quite familiar, like REM behavior, we are going to talk more about those when we move on. And so this was what this person wrote to me. These are the things that are bothering me right now. This second case was a 66-year-old woman with a 9-year history of Parkinson's. She was writing to me, she was unable to complete her physical therapy sessions because she had low blood pressure every time she would stand up. What happened, she would go into physical therapy, she would try to do the activities and get really dizzy and lightheaded, and physical therapy would say, I'm sorry, we can't continue with the session. I'll let your provider know. She tried medication for it. It didn't help to the benefit that she needed. She was requiring more assistance with activities of daily living. Most trouble was getting in and out of bed into the bathroom. And then she had urinary urgency, incontinence, and sexual dysfunction. When she wrote to me, these were the things that were bothering her the most. So I just want to, you can put them in the chat if you have thoughts on these messages. Otherwise, let me just go through them again, highlighting what their biggest concerns were: agitation, irritability, mood, sleep, REM behavior disorder. The second one was low blood pressure, lightheadedness, urinary urgency, urinary incontinence, and sexual dysfunction. And so when we look at these, I don't know if you see the theme, but there isn't one mention of a motor symptom. These people with Parkinson's are very bothered by the non-motor components, and they can be extremely debilitating for many people. When we look at this graph, you may have seen this before. It shows us nicely kind of a timeline of what we typically can see on average, or what literature has showed us. So we know that at time 0, when you see that 0, that is the time of diagnosis. Anything before that are prodromal symptoms: constipation, REM behavior disorder, depression, mood, loss of smell. Those can prelude a diagnosis by up to 20 years. And we know that that is very much in the literature. Time of diagnosis starts at 0, and then you can see as it goes to year 10, year 20. Some of these other things can occur. Motor fluctuations with dyskinesia, that dancing movement, more off time. But we also see that space getting bigger with the non-motor symptoms. And that is what really becomes very bothersome for many people. So we're going to talk about the advancing non-motor symptoms, and as it relates to the clinical implications that we should be thinking about, looking into, or understanding, so we can identify these early. Many of these, as I mentioned, are what make up many of the most bothersome symptoms for many people we see. Not only later in the disease, which we typically do see these as it advances, but they could be bothersome right away, like sleep disorders, for example. So when we look at mood and cognition, depression, anxiety, apathy, the feeling of like, I don't really care anymore. It doesn't matter if we go or not. Do you want to go see family? It doesn't really matter. That apathy comes into play early often. There's concern for suicidal ideation, Parkinson's disease, dementia, or psychosis. And those are all falling under mood and cognitive changes that we can see. So when we look at the cognitive function and behavior, memory impairment is something that everybody looks to and thinks about as we age, right? As we mature. And some of those things that we can see are in memory impairment would be paying attention or concentrating, multitasking, problem solving, sometimes getting one process step to the next. And so that process of things can be challenging for people. Interpreting where objects are in space, maybe short memory loss for some people. Again, this may not apply to everybody. And that bradykhrenia is that slowness of thinking. This is a really big challenge for people. And sometimes you don't even recognize it, but as a care partner, as an adult child, even as somebody living with Parkinson's, it's important to understand Because I hear this often. I want to go out with my friends, but when we're all standing there talking, there's other noises going on. They're in a conversation, and by the time I want to get out what I want to say to contribute, the conversation has moved on. I can understand what they're saying, but it takes a little bit longer to process that. Oftentimes when this is occurring, that asking questions that are yes or no answers help a lot. And so it's important for the provider to know. It's important for care partners and loved ones to know, because they can really help aid in that, so you can be part of that conversation. And then we can see Parkinson's disease related dementia. There are medications for these as well. Psychosis, Parkinson's disease psychosis. This can be part of the disease progression. This can be because of an insult to the body, like an infection. In fact, people who have Parkinson's who develop a urinary tract infection, if I get a message on my chart that says, so my loved one is having hallucinations, the first thing I would do is order a urinary sample, a urine sample, because that's one of the first indications. And often it can happen with anybody, especially 70 and older. We see hallucinations within psychosis, which are hearing or seeing things that are not there. Illusions, which is seeing something that's there, but it looks different. Like your bedpost, you can see it, but to you now it looks like a person. Or delusions, which are beliefs that are not true. Sometimes there's paranoid thoughts. What are you putting in my medication? Are you trying to poison me? Those are, just some examples of what can happen in psychosis. That can be treated through medication or through finding the underlying cause. Sometimes a new medication can also do that. There is depression, anxiety, and apathy as well. Sometimes the anxiety, I just want to mention, can be on part of the underlying disease. It could be something that that person already just has been dealing with, or it can be part of the phenomenon of turning on and off. So if they're feeling good, they're on, their dopamine levels are where they need to be. They feel pretty good. One of the first indicators for many people that they're wearing off is that sense of internal anxiety. So speech and swallowing is another big non-motor feature that we talk about. The more than 80% of people with Parkinson's disease will develop some form of dysphagia. And that doesn't mean will be severe, but you could have some form of dysphagia. So understanding and identifying it early is critical in helping maintain, good quality of life, good outcomes. We can see hypophonia, which is that quiet talking, stuttering, dysarthria, which is like a thick tongue, slurred words. Siluria is drooling. We can see that in 30 to 75%. That's pretty big range. Dysphagia is the swallowing. And then mutism. I've only really ever had one patient that truly developed this, but it can be seen in advanced and very severe cases. With any of that, we worry about weight loss. If you're having trouble swallowing, is that a reason you're not maintaining nutrition? So early identification, early intervention with speech therapy is critical. The sleep disorders, I don't know if anyone here can relate. This is a very, it's such a large phenomenon to Parkinson's. It can happen, like I mentioned, 20 years prior to a diagnosis. It can be the most difficult thing that we deal with the entire journey. Some people just have a very hard time with sleep. Many different forms of sleep disorders in Parkinson's disease that we see, like insomnia, REM behavior disorder, which is hitting, kicking, punching, talking in your sleep. What happens with those vivid dreams in REM behavior disorder is you're awake state where you're awake, and then you have this deep sleep. That's the REM sleep. In REM behavior disorder, you're floating right above REM sleep. So you're like in this awake state, but you feel like you're sleeping. You wake up and you're like, gosh, that was great. I got 8 hours of sleep last night. And your bed partner's like, are you kidding me? You were talking all night, you were kicking, you moved all the blankets, the dog jumped off the bed. You didn't sleep at all. what that contributes to is excessive daytime sleepiness and like more medication need, unfortunately, because sometimes you're not feeling on because you're so fatigued. And it can give us as a provider, it can give us a false need for increased medication. So it's a very critical thing to get addressed. Sleep is maybe not identified, or poor sleep is maybe not identified enough or early enough. So it needs to be addressed if you are dealing with any of this. I was just going to show you a video here of somebody with REM behavior disorder. This was taken like in 1986. So it's a very old but notorious REM behavior disorder video. So I'm going to show it here. Moving? I don't see it moving on my screen. Are you guys seeing it? Eden? Okay. So hopefully you could see that. Okay, good. I'm going to move on to the next screen because my computer doesn't like me on the screen with the video. But that is something that we see, is that REM behavior disorder, it interrupts bed partners, it interrupts a person experiencing that, it interrupts their sleep. Very important to get addressed. There are medications, there's things that you can do without medications. In fact, there is even like therapy through with neuropsychologists that can help with sleep. So there's a lot of things that can be done to treat sleep, practicing good sleep hygiene, and really important to get addressed. So we'll talk about pain. Pain can come in many different forms: musculoskeletal, dystonic, central pain, neuropathy. We see an increase in neuropathy sometimes with people living with Parkinson's. And up to as many as like 50% of people with Parkinson's can experience the tingling and numbness in their extremities. Maybe this is related to, some of the pain is related to rigidity, stiffness, the immobility of movement. And otherwise it could be from postural changes. We see different posture changes within Parkinson's disease. And then there's also a sense sometimes for some people, this sensation of just an internal jitter, internal need to move. It's this restlessness called akathisia. Well, let's talk about autonomic dysfunction. This is a big, I could probably just talk an hour about this. Autonomic dysfunction is many things are encompassed within this, and it can be a very debilitating component. In fact, some of the case studies that I showed you had many components of autonomic dysfunction. So low blood pressure upon standing, the urinary changes, sexual dysfunction, all of those. So we'll talk a little bit more. Autonomic dysfunction is also called dysautonomia. So you might hear it called that. It is, I like to think of it, and I like to tell people the easiest way to think about it is autonomic, automatic. So your automatic functions that you don't think about, like constipation or urinary function, sexual function, smell and taste, blood pressure, all of those things. So let me tell you about some of these. The orthostatic hypotension, that is when your blood pressure drops upon standing. It's also called orthostasis. And typically when you stand up, your heart and your extremities and your brain, everything works together to move the blood to adjust to the postural change. In orthostasis, that doesn't occur, or not as fast. So you're left with the lack of blood getting to where it needs to go fast enough. You can get really lightheaded, really dizzy, and this unfortunately contributes to a lot of falls. So orthostasis is something that can happen with the disease progression. And we also compound that heavily with many of the medications that we use to treat Parkinson's. Many of those can contribute to orthostasis. First thing that you do with orthostasis is strip away medications, making sure you don't have one that's contributing. And then we try to find, is it the underlying disease process? There are medications to treat that, of course. Constipation, again, something that can occur 20 years prior to even a diagnosis. The reason this can be a really big problem, especially as the disease advances, is that we can see the absorption change. And so if you take a medication and you have slow motility of the GI system, a medication might sit in the stomach for far longer than what is anticipated, and therefore you never get the benefit of that medication. So this peristalsis, the slowness of the GI tract, is extremely important to get addressed and to make sure that you are working with your provider or with GI to help address the issue. Loss or change of smell and taste, sexual dysfunction, urinary changes can occur. Rhinorrhea is the dripping of the nose. Sialorrhea is drooling. And then heat and cold intolerances. You might always have cold feet or warm feet. The oily or patchy skin can occur in Parkinson's, and that's all autonomic dysfunction, and then excessive sweating. And so all of these things can be treated. There are things that we can try to do. Many of them require medication, pharmacological intervention. Not all of them, but many of them do. And that's a problem, right? Because what we see again is that this leads to, again, polypharmacy. And so as we look at the clinical implications, the clinical considerations of Parkinson's, we know that polypharmacy is perhaps inevitable, not always, but you have to just be really looking at what is bothering you the most. What are things that you can do without getting medication on board? And what are things that really require that to give you the best quality of life? We can treat mood, cognition, sleep, orthostasis, sialorrhea, constipation, we can treat all of those, but they all might require a medication. So let's talk about the social implications. It has been become very clear in that Parkinson's disease involves a variety of social symptoms. And although these are not as well understood as the motor symptoms or the non-motor symptoms, they are extremely important to understand and recognize as a care partner, as a person living with this disease, and as a provider. So these different social issues can greatly impact the patient, the person living with Parkinson's, their families, and can ultimately reduce quality of life. So it's extremely important for us to understand what these are and what these mean. Let's talk about stigma. This might be something that we all have put on Parkinson's disease without even knowing it. Often some of these social issues are, without thought and unconscious perception, but stigma has primarily negative effects on those who experience it. Moreover, self-stigma can occur in individuals with a chronic health condition such as Parkinson's disease, and it can further amplify negative effects from the public stigma. So, with public stigma, we see it, or with the internal thought, psychological distress, reduction of self-worth. And so it can not only affect how a person views themselves by others, but how they view themselves. And that can be very detrimental. We look at facial masking, and this has been studied often with different paralysis of the face, different conditions, stroke patients, people living with different neurologic conditions, as well as facial masking in Parkinson's disease. And so the studies do indicate that facial masking is a contributing factor to perceptions of stigma. Of course, right? We know that when you look at someone with facial masking, it may be that person maybe has the inability to appropriately articulate emotion. So they might look mad, they might look scared. And really that's not anything that they're doing, it's part of the facial masking. They are often misunderstood, and it could leave an unfavorable first impression, which all can relate to stigma. One study that was recently done found that stigma associated with facial masking was the main reason for reduced quality of life in Parkinson's for some people. And so that was a really interesting thought. Stigma has a large play in all of this. So what can we do? What do we know about it? Why do we educate ourselves? This is why. It's important for people who are, who are caring for or who know somebody with Parkinson's disease to understand what symptoms can come. Dysarthria, the inability to maybe articulate the words, some slurring. Again, the person with dysarthria might have that prosodic loss, the tone inflections. They might sound more monotone at some points. This may fluctuate, maybe only in their off time. But that can also relate to someone feeling misunderstood, and they can face discrimination because of that. So very important to understand and recognize how stigma can play into a social consideration. And then we'll talk about dehumanization. This is really characterized by a denial of the capacity for experience of another person. And it really is an unconscious perception of others. Unfortunately, dehumanization is a common occurrence in both formal and informal settings. So formal being in a healthcare setting, or even just informally with your family and loved ones. When we look at modern healthcare settings today, we see that maybe you get 30 to 60 minutes with your provider. And that's being generous, right? You might not always get 60 minutes with your provider, but if you go in there and you want to talk about head to toe what's been going on, it's really hard to get all of that out. And it's even more difficult for some people when there is a communication deficit. So what I would always recommend is write down as you go between appointments, those intervals in between. It sounds cliche, but it's so important to be writing down what is bothering you so that you remember when you go to that appointment. If you can't write, if you don't want to write, make sure you're telling your loved one or putting it on a voice recording, something so you remember what you want to bring up in your next appointment. When we have such a shortened time, like I mentioned, what bothers you most? We try to focus in on, or I do, I always tried to focus in, what is the most bothersome thing that we can help address today? To extract that important information from somebody living with Parkinson's, we take a lot of the nonverbal communication as a way of assessing how well the patient's doing, or how well, what things have changed since I've seen this person last. And that strategy, unfortunately, can be very ineffective for someone living with Parkinson's disease who experiences a communication deficit. It's not really fair to maybe judge them by what they're telling me, what their body language is when there's facial masking, when they're off, when they're having changes to some of these things. Due to the facial masking or dysarthria or stuttering or bradykhrenia, that slowness in thinking, it can take a person living with Parkinson's disease much longer to communicate what their needs are, what their questions are. And in some instances, we see that the care partner or the adult child will take control of that appointment to provide the clinician with the really important information. They get it out more quickly. And although it might be effective to get the information across, it can be very detrimental. That person sitting there who just got talked over and who was unable to tell the provider themselves might feel as though their voice is not heard, and that makes them feel dehumanized. It's a very difficult thing to understand, especially when you're dealing with, come on, get it out. We only have a couple minutes. That can be very challenging, but writing things down can help address some of that. Or using like the messaging system with your provider in between visits can help address things so that when you get to the visit, you're really just addressing a new thing or something that's really been bothering you. So in dehumanization, people feel, that loss of voice, both physically and figuratively. The short appointments with long intervals does provide significant challenges for people. Sometimes you feel like there's a loss of independent decision-making. Again, that comes by sometimes complete accident, by just a care partner or adult child, somebody talking for you. And yeah, that sounds great. Yeah, let's do that. Is that okay? They didn't have time to answer, so you just nod your head and say, yep, that's great. We'll do that. When really the person sitting there was taking it all in, but unable to get the word across quick enough. And they had more questions, for example. And relying on body language is not often reflective. That is in, again, a formal healthcare setting, but also in an informal setting at a friend's house. So really important things to share with your loved ones and to help other people understand, so that you can do the things that you need to be social and to stay social. And speaking of staying social, one significant impact of dehumanization and stigma is social isolation. And the stigma can lead someone with Parkinson's disease to avoid social interactions, or just avoid disclosing information about themselves because they don't want to be thought of in a negative way. Repeated social isolation puts someone at risk for experiencing loneliness. There has been many studies done. These are just two examples, but there's been many studies on social isolation and how it impacts quality of life. More yet, there's been many studies done on how social isolation affects somebody living with Parkinson's disease. And with COVID, we saw a new, a resurgence of research being done on the impact of isolation. And significantly, we saw poor outcomes and worsening mobility, worsening cognition, more difficulty for the care partners. It's all around. Isolation and loneliness do not do well with somebody living with Parkinson's. And these results really call for increased vigilance, like towards non-motor symptoms in people with Parkinson's experiencing social isolation, to have a stronger focus with their provider on addressing these, and really maintaining with your care partner or independently, going to support groups, finding that social connection in your community, whether it's online like this today, whether it's in your hometown. It is critical to maintain those social networks, because that engagement is something that can improve your quality of life. Somebody who is working and they have Parkinson's disease, I got this question all the time: should I stop working? If you feel good, if you can do your job, and you're absolutely not. Work as long as you can, because of this. We don't want you to start isolating yourself. So just another component to something that we would take into consideration when we're looking at the overall social considerations. And we can't talk about social implications without discussing the financial impact. The annual, I think it was the Journal of Managed Care that put out the annual economic impact of Parkinson's disease in the United States, is estimated to be around 10.8 billion. This might have been when we thought it was 60,000 newly diagnosed a year. But we know that it's actually closer to 90,000 that are newly diagnosed in the United States alone. There is no, the mental, the emotional, the social cost of Parkinson's disease on people living with Parkinson's, on their families, on their friends, that cannot be quantified. But we can look at some of these statistics, like medications. That's just the average cost that drugs can commonly cost a family or a person who's living with Parkinson's disease annually. That might even be after insurance for many people. But medications are no convenience either. Surgical treatments can cost upwards of $25,000, and that's probably a low number. As the disease progresses, for some people with advanced or late Parkinson's, we might consider being institutionalized to get better care or more safer care for that person. And that can exceed $100,000 a year for that family or that person. What is clear, which is encouraging, is that the investment in medical research that leads to better treatments for Parkinson's disease can save millions of dollars a year. And there are studies that have indicated that for every dollar spent on high quality research, roughly $13 can be saved in direct and indirect costs. If there's a new therapy that could be found and that could even produce like a modest 10% delay in progression, we could save hundreds of millions of dollars. So every piece of research that contributes, it might not seem like a big impact sometimes, but it is. It really is. We're working towards even more than that, right? We're working towards a cure. The indirect costs aren't even mentioned here, but that can be, loss of income, disability payments, medical costs, of course. So all of those. And around 20% of people living with Parkinson's who have late stage Parkinson's, this very late stage Parkinson's, are institutionalized. And usually if you're institutionalized, it's because of a loss of independent activities of daily living. And then we would see somebody more so in a nursing home setting versus assisted living. We see that a risk increase for being institutionalized with psychosis, where it's a risk factor with 25% of people living with Parkinson's who have psychosis being institutionalized versus just 1 in 10 without psychosis. And we know that risks of being institutionalized or being in the hospital, things that can increase pneumonia, aspiration, things like that, dementia, being disoriented out of your normal setting, all of those can play a role in that as well. And then I would be remiss not to mention within the non-pharmacological approaches for late stage Parkinson's disease, but even not late stage Parkinson's disease, is to consider something within palliative care. Palliative care includes a broad range, and it aims to improve the quality of life for someone living with Parkinson's disease or a chronic condition and their families. It is no longer considered or restricted to end-of-life care, and it's a huge misconception. It is not hospice care. Palliative care is integrated with your traditional medical care. You can still go to your neurologist, you can still be on your medications, you can still go to physical therapy, you can still be part of your support group, and you can be enrolled in palliative care, getting additional support. You can, we consider it really truly multidisciplinary, part of the collaborative team. And we're finding that early implementation, whether you're inpatient, institutionalized, or outpatient, makes a big difference in having everybody on the same page and everybody understanding what your needs are. If you're living with Parkinson's, what the family's needs are, who is the best resource. Palliative care is amazing at helping with resources, and that's something that we should always take into consideration, not just as an end of life or advanced stage Parkinson's. So with that those are some of the biggest social implications and considerations that I think are worth identifying and being aware of as it relates to Parkinson's disease. Both motor and non-motor symptoms have clinical and social implications, and early identification, early intervention will really help with the quality of life and outcomes. I've left some time. I know I see the chat moving, and so I've left some time for questions, and I thank you for listening.
I always appreciate, I feel like people get scared when they hear palliative care, and like you said, it's not what it was, and it's really just planning for the future and getting in touch with people who have good resources. And now I'm going to jump into the questions. Someone asked, does dementia always accompany Parkinson's disease, or is that just for some?
Yeah, thank you. Great question. It does not always accompany Parkinson's disease. Every single motor and non-motor symptom that I mentioned, those are going to be different for every person. I think that's what makes our job as clinicians so difficult, And probably the frustration high, because not one person living with Parkinson's disease will experience the exact same thing as the next person. You could put 100 people in the same room and I can guarantee you not two alike. And that means the severity of symptoms, the symptoms they're experiencing, motor, non-motor, medication tolerance, all of that can be very different, and it varies significantly. I had, I had two patients who were 99. One of them drove herself to every appointment. One was still in Dancing with Parkinson's. Neither of them had cognitive deficit. So it's so variable.
Can you talk about the difference between REM behavior disorder and sleep apnea?
Oh, good question. Sleep apnea is really an interruption in the appropriate amount of oxygen throughout the night. And sleep apnea, we actually do see a higher incidence of sleep apnea in Parkinson's disease. It's really important to get a sleep study if you're experiencing any poor sleep habits at night, or you wake up feeling tired. A sleep study can identify sleep apnea. It can identify REM behavior disorder, insomnia, restless leg syndrome, many of those things. Sleep apnea occurs when there's really periods of not breathing, or not breathing as effectively as you need to be. It is often treated with a CPAP or a BiPAP machine. I can't tell you how many people I have seen in clinic who have terrible days. They can't get their medications right. We find out they have sleep apnea, which is untreated sleep apnea. They correct it using a CPAP, and a world of difference. Their day is a world better. It can take months, several days to months, to correct that deficit. What happens in sleep apnea is if your oxygenation should be above 90%, your oxygenation, your O2 sat, you might have gotten your saturation measured before on your finger. And in sleep apnea, sometimes it's down in the 70s or 80s, which can be very detrimental. It's not getting the oxygenated blood where it needs to. When you wake up in the morning, you carry that into your next day. You might not be sitting at above 90. You might only be at 84. And that really isn't going to give you the amount of oxygenated blood to have all of that energy and, the appropriate, I guess, equilibrium in your body. REM behavior disorder is truly a disruption of REM sleep, so that you're not sleeping in this deep quality sleep, but instead you're actively sleeping. You're in this active state of sleep.
This is felt good. So there's a fine line between when a care partner goes with their loved one to a doctor's visit, and they sit in front of you, and you're like, what's going on? And the person with Parkinson's is like, everything's great, everything's fine. And the care partner is like, it's not what's happening. There's kind of that fine line, because they don't want to be dehumanizing to their loved one. But at the same time, if they don't speak up, then you're not getting the full picture. How do you suggest handling that? Because that is that fine line between, I don't want to speak over, or, kind of like when your kids were little and you took them to the pediatrician, and, you're going to tell the doctor what's going on and things like that. Your child's not really, at most they'll say, well, my ear hurts, but you would say, well, this is happening and that's happening. How do you deal with that?
Yeah, as a provider, I always ask the person with Parkinson's first, A, B, C, D, and then I look at the care partner. Is that accurate to what you notice? Is that how you interpret things? If they have a difference in it, or if they're like, no, it has not been the same. That has not been stable since your last visit. Can you tell me more? Is it okay if is it okay if your spouse tells me more? As a team, what I would suggest that you do is, before your appointments, if you're going with, they probably want you there for a reason. You are there to help remind them, oh yeah, you're right. I guess I haven't been sleeping. Maybe ask before you go to the appointment, is it okay if I talk to the doctor, the provider, about some of the things I've been noticing and just get that confirmation before you go in so you can speak up as a care partner and feel more comfortable. Also writing things down as you go. Remember last week when you said you saw like a person standing there? Can we talk to the doctor about that? Let's write it down so we don't forget. So those are just some things that I would encourage you to do. The other thing is you could always message your provider. You don't want to go behind, your loved one's back, but you could always message and just say, these are some things that I've been concerned about. I would love to talk about them at the appointment. Will you ask about this?
Someone asked, is there any difference in late stage Parkinson's for someone who was diagnosed at a young age, like say 40 and is now 65? So now they've had it for 25 years, but at 65 versus the person who got it later and is now 80, for example.
Yeah, when we talk about staging, when we look at that Hoehn-Yahr score, when we look at advanced stage, late stage, that is not saying, oh, you've had it for 30 years, you are a late stage. That is looking at that individual person and where they are as far as dependence or independence, as far as motor complications, non-motor symptoms that get maybe taken into account. So great question. It really is more applicable to where you are as far as your independence, your mobility, your ability, versus when you get it. We do know that research has shown us younger, usually we often tend to see like this slower motoric progression.
As always, what would a Parkinson's presentation be without a question about constipation? The nurse practitioner I used to work with, she called it the constipation carousel, because you'd be all blocked up and you would take something and then you had to take something to stop it. And so somebody asked, because you talked about the constipation and medication being stuck in the stomach, how everything slows down. Other than more medications, are there things to help with dealing, like a Metamucil, for example, or Floridex, to help moving the pill along, or does it then just kind of rush it out of the system?
Yeah, no, I think if you are really dealing with constipation, we always recommend something like Metamucil, making sure you're drinking a lot of fluids, exercising to help move, just keep your body moving, wake it up a little bit. There isn't really a perfect diet in literature for Parkinson's disease, but we know that the Mediterranean diet is something that could be easily followed, mainly because it has a lot of high fiber foods, greens, vegetables, but it's also small meals frequently. The small meals are what happens when you eat a big meal, whether it's high fat or not, goes into the stomach and sits. You take that pill, it goes and sits. They're fighting for absorption and they're fighting to be absorbed in the stomach. So if you're eating smaller amounts, it helps absorb food easier. Talk to your provider, but sometimes we even have, Miralax, if that is a medication, but something like that as a daily or every other day option. But Metamucil, fiber, just make sure you're drinking extra fluids with it.
A question, I guess I'm going to call it, say it's kind of a question about advocacy. I've always heard this a lot from some of my the patients, that sometimes they're not being taken seriously by their doctor, and she's wondering, how can we get, for example, a sleep study? How do we advocate for ourselves when we're not being offered these options since we're older? Late stage Parkinson's patients, in the office visit, what can they do to kind of advocate?
That is a very great question. It's so important. If you don't advocate for yourself, I can tell you right now, nobody else will. And so you, as the person that needs the advocacy, or your care partner, that is such a critical thing to getting the right care. Whether you're outpatient seeing your neurologist on a standard interval, or if you're inpatient. So some of the things that I would say is asking again, saying, this is what you're saying to me makes sense. Thank you, doctor. But what is bothering me most is ABC, and I really want to get this addressed. If they're not listening to you, I mean, obviously it takes a lot of work, but you can always get a second opinion. That to switch providers is tough, and that's not always the right option. As a care partner, I would say making sure that you address it at the beginning of the appointment, the end of the appointment, making sure that it's the forefront of this is why we're here today, and what can we do to make this better. I mean, it just has to be something that is continuously asked. If the provider that you're seeing really is completely dismissive, maybe you're not seeing the right person. One thing you could always ask for is a social work referral. Many bigger clinics have a social work on site, but social work can often help advocate for you and find you resources as well.
And now this comes up, it's very common, bothers the care partners the most is the masking. Can anything be done? Because it's just it's difficult to speak when somebody is just looking at you sort of unengaged, even if they are inside engaged, when they're kind of just bland on the outside. Is there anything that can be done?
You know, sometimes it's responsive to levodopa or the medications that you're taking to fill the gas tank back up. And often it's an indicator that off time is coming because they start to have some, facial masking, and maybe that's an indicator that, oh yeah, I'm not on. So sometimes it really is part of that fluctuation. If you're seeing more of that, maybe it's telling you that maybe there's more off time and medications need to be addressed. Working with speech therapy can help with that, the different tones of melody that comes out. Sometimes that helps, but it's a very challenging thing. I guess my biggest thought on that is, yeah, it is hard. It's hard to see somebody who's like looking like they don't care at all what you're talking about. But I just try to think of what that person is feeling. That's even more difficult to accept in my heart, to like what they must be feeling when they want to be able to, show joy or show emotion and they can't. Being able to understand that, going to support groups of other people who are dealing with the same thing can be really helpful. But really looking also, if it's an on-off thing, can be important.
Ask just a couple of quick ones because we're almost out of time. Are there any oral dysfunctions identified, like biting the cheek or tongue while eating or even talking?
That can happen. Yeah, that can certainly happen. It's not a known symptom, but a couple different things. Sometimes when there's issues with drooling or dry mouth from medications, one or the other, that can cause disruption in how your tongue moves or how you move food. And so sometimes it can cause you to bite your cheek more often. Sometimes there's different tremors, or I've even seen people with tremor, or dyskinesia near their palate, and that can contribute to some of those disruptions as well.
This I'm going to just ask you to speculate on, because obviously this person is not your patient, but I know this comes up a lot for the men and the women. Frequent nighttime urination, would that be something they need to discuss with their Parkinson's doctor or perhaps a urologist?
Yeah, I kind of love this question. To be honest, this and low blood pressure, I will tell you what I would always say. We can blame everything on Parkinson's disease. Okay, that's easy. I can guarantee you many of your other specialists or your general practice doctors or providers want to blame a lot of it on your Parkinson's because it's easier to do. But not all of it is Parkinson's. So I always would say, get a referral to urology, get a referral to cardiology. And then if they can't find anything wrong, ophthalmology, whatever it might be, then we can blame it on Parkinson's and then we'll figure it out. Men over 60, I'm sorry, it's one thing that we know is a very high prevalence of enlarged prostate. Frequency of urination overnight, that can be because of that. I like to rule that out before I blame it on Parkinson's, although urinary dysfunction is a component of Parkinson's as well. So always get that referral, and peace of mind, you understand what's going on.
You did kind of touch on it about the cardiology because someone asked about the blood pressure because they're like, as you get older, also the blood pressure can be high, and then Parkinson's causes the low blood pressure. And so they'd probably do better to go see a cardiologist as well.
I always partner with cardiology anyway when I'm dealing with it because it can be so complex. Specifically if you're on a blood pressure medication or have any cardiac conditions, it's so important to get them involved in that care. I often sometimes let them manage it. I would say that low blood pressure is very common in Parkinson's disease, but it gets exemplified and even higher risk of that when you add on these medications.
Well, thank you so much. As always, because we are out of time, we have our tradition here at PMD, our wave of gratitude. Thank you so much, Kelly. We really appreciate you coming and chatting with us today. And I hope everybody has a wonderful day. Thanks so much.
My pleasure. Thanks, you guys. I'm open if you need to email me. Okay.